Good afternoon, respected judges and my dear audience. My paper is Novel Artificial Intelligence Derived Dry Eye Analyzer. Is it here to stay? I have no financial disclosure in this presentation. DUCE 2 in 2017 have published the renewed definition of dry eye disease, and though the definition and the classification of the disease is seemingly clear, no gold standard test for diagnosis exists. A Google search of setting up a dry eye clinic yields more than 3 million results in less than half a second, and the literature review of imaging in dry eye shows multiple devices like corneal topography, AIOC2022, wavefront aberrometry, infrared thermography, tear film imager, tear lab osmolarity system, inflamma dry. And it is of course not possible for a single ophthalmologist to obtain all of these. This is where the multi-imaging integrated device comes into play. Our purpose is to evaluate the role of novel artificial intelligence derived dry eye analyzer in patients with ocular surface disorder. It is a prospective study. Our sample size is 250. All the patients underwent ocular surface disease index questionnaire. Then they were subjected to dry eye analyzer. The traditional test of Schirmer and ocular staining were also performed. In the AI-derived dry eye analyzer, they were first subjected to non-invasive breakup time, tear meniscus height, infrared mammography, and lipid layer interferometry. The OSDI scoring were graded into mild, moderate, and severe depending on the chart here. Non-invasive breakup time uses Placido's disc projection using visible light, and it looks for distortion of the Myers, and it gives the first breakup time, the average breakup time, the breakup distribution, and generates a map like this. Tear meniscus height is measured with an inbuilt camera, and this is measured in line with the pupillary center. This is a normal. The left side figure is a normal tear meniscus height of more than 0.2 millimeter, and this is an abnormal one in the right. Infrared mammography is based on the principle of autofluorescence of healthy mabum when it is focused with an infrared light, and it is captured by an infrared coupled camera device. This is the first image that is obtained, and this is the second image, which can tell us about the gland loss and the gland dropout. The figure on the left is a grade 1 MGD, which has very minimal loss. The figure in the right has a loss of 78% gland loss, and this is a grade 3 MGD. Lipid layer thickness is based on interferometry. It is when a bright light falls on an oily layer. Then in the figure over here, right bottom and right up, which is grade 3 and grade 4 lipid layer, you will see a lot of colorful fringes. But the figure on the left, if it has a thin oily layer, then the fringes are almost absent, and it is a colorless pattern that we see. Our results show Schirmer was positive in 51% cases, and out of them 11% had severe dry eye, 38% of the patient had positive corneal staining, 18.8% had NI beauty less than 10 seconds, tear meniscus height was less than 0.2 millimeter in 9.4% patients. Lipid layer analysis have shown 51% of the patients having less than normal tear lipid layer. Mammography showed 56% of the patient had some form of meibomian gland disease. We have done a correlation between the various test parameters, and the figure which shows the minus values show that there were no correlation between these two tests. The figure in the green, the values on the green show there was a high correlation between OSDI and lipid layer, OSDI and mammography, Schirmer and staining, some correlation between mammography and lipid layer, a very high correlation between NI beauty and tear height. The overall results show that though all the patients were having signs and symptoms of ocular surface disorder, 23% of the patient did not actually have dry eye. This bar graph is showing the overall positivity in all the test parameters, and 9.2% patient had positive result in all parameters. So what we already know of this multimodality imaging devices is that these are automated, these are non-invasive, they do not require an ophthalmologist to make the diagnosis of dry eye. It is less time consuming, and it makes the monitoring easier. So what our study adds, meibomian gland disease and abnormal lipid layer thickness contributes to more than 50% of the cases. Cases hetero missed by the traditional test. In this particular study, 14.4% could be detected by this device. Dry eye analyzer, when used in conjunction with traditional test, is complementary. Limitation being small sample size and monitoring patient scores over time was not done. What is the translational potential of the study? We can identify deficient layer of tear film. In that way, we can do imaging-based targeted therapy, and this is the color-coded map that is generated. So when we show this map to the patient, it helps to raise their awareness, and in a way, it can increase the compliance level of the patient. Thank you very much for your kind attention.